Welcome back to New Money. We're discussing healthcare this evening. My guest, Roseanne Harris. And if you'd like to email me, you can get my email off the screen. Roseanne, let's just talk about the smaller schemes. Certainly, how are they, if they're not attracting individuals and they get into trouble, what happens to the members? Can they, if they've been members for a long period of time, can they automatically migrate to other schemes without all the 3-month waiting and the 12-month exclusion, whatever the case may be?
So the Medical Schemes Act does provide some protection for people moving between medical schemes. But as you say, if you elect to move between medical schemes, so not as part of your change in your employment, for example, then you will face a waiting period. But the importance is that won't apply to your prescribed minimum benefits. So your access to prescribed minimum benefits is secured. So even though you might face a waiting period if you're on a chronic medication, for example, and that's a prescribed minimum benefit condition, then the waiting period actually wouldn't apply to that. So, important to make sure that your financial advisor is giving you that information around, what the actual impact of the waiting period is, rather than, just seeing it as a blanket block.
Can you share in 45 seconds what prescribed minimum benefits are?
So prescribed minimum benefits are essentially it's over 300 conditions, but broadly speaking, it covers things like your acute urgent hospital treatment, quite a wide range of hospital services, so most emergency benefits. It covers a list of chronic diseases, so I think there's now 27 on the chronic disease list, and it covers the medication and the management of those conditions. It covers maternity and childbirth, and it also covers a number of cancers and things like dialysis. There will be clinical entry criteria, so in other words, clinical criteria that you have to meet in order to be eligible for the prescribed minimum benefits, but those are based on proper evidence, clinical studies and so forth to support that.
And whatever scheme you're on.
Whatever scheme you're on, you have to be covered for those things, and they can't run out. So, this notion that medical scheme members get to April and they've run out of benefits, it's not true. You can run out of certain benefits, but in terms of some of these major events,
life-threatening
events, you can't run out of that cover. And that, as I said, is the real value that medical scheme benefits offer, is that when you really need it, you're going to have cover for those big ticket items.
Talk about NHI. Are there any legal actions still going on? Where is it?
Oh, there are so many legal actions.
And one of the reasons I've got a vested interest, because over the 3 budgets that we had, I was always listening only to one thing. Were they going to remove the tax credits, particularly for those over 65 and those earning less than $1 million?
Yeah, so there's a bit of an update on the tax credits. Actually, as a result of the litigation being in play, we do have some clarifications on this coming from the Department of Health, which is quite helpful. So we now have, I think it's 8 litigants involved in the NHI, and it really is, quite a legal mess. So at the moment, there's some procedural challenges around the way in which the NHI Act was passed into law, and there are also a number of substantive challenges which are looking at the constitutionality of the Act itself. And there's a whole process about whether those should be consolidated and deferred, and as I said, it is a real legal mess. But what we do have is now affidavits from the Department of Health clarifying some of these important aspects. So one of the important aspects that's been clarified is that there isn't an intention, so there is no intention to remove the medical scheme tax credits for people who are earning less than R1 million. That's really important, because actually that is over 80% of medical scheme members, actually. So the vast majority of medical scheme members, the tax credit is secure, and the affidavits also state that medical scheme benefits are not going to be affected for at least 10 to 15 years. So that's a pretty long time horizon as compared to kind of a lot of the anxiety around when the Act was passed, that people thought that this was going to immediate. So it's a very phased approach that's been taken to rolling out the NHI, with quite a narrow group of people initially who are going to be focused on in terms of some of the pilot benefit packages, and then the medical schemes not affected really for the foreseeable future.
And tax credits for over 65?
So tax credits for over 65, it seems that those are secure, except of course it's just this threshold of, depending on earnings. So people over R1 million, we're likely to see some kind of restructure of the tax credits, but that's probably only going to be post 2027.
Okay, well, let's get some emails. Leslie Nungsanga says, what effect does fraud have on medical aid contributions? And could you also outline the common types of fraud and in non-actionable terms, how schemes detect and prevent them?
Yeah, very important question. Thanks for that.
Yeah.
So there's a number of ways.
Firstly, is that a big contributor to the cost increase?
Well, it is from the point of view that if we didn't have the measures in place that we do have for combating fraud, I mean, it's a big investment for us as a medical scheme administrator to make sure that we have the systems in place. And the recent investigation by the Council for Medical Schemes, the panel confirmed that there's an obligation for medical schemes to have these processes in place to make sure that we are detecting and acting where we are picking up fraudulent behavior. We estimate that if we didn't have those measures in place, that medical scheme contributions would be about 11% higher. That's really significant. That's almost like 2 years of additional contribution increases. So it's important that we have these measures in place, and they need to be obviously fair and reasonable measures, but we detect the fraud. Actually, our most common way of picking up these cases is from people letting us know. So on their benefit statement saying, this is not a claim that I actually incurred, or I have observed certain practices that don't seem to be sound to me. So roughly two-thirds of the cases that we are investigating, we are picking up through tip-offs and complaints and those types of things. The balance we pick up through the analytics, and you mentioned AI earlier. This is one of the areas that we're able to use these tools quite successfully in terms of picking up where claims don't look like they are genuine, and acting to recover those and protect member funds. The most common kind of fraudulent activity is actually just straight claims being made and the service was never delivered. The drug was never dispensed, the service never took place. Sometimes there's collusion between the doctor and the patients. Those are particularly difficult to pick up, and there might be some kind of cash inducement that when the claim is paid to the doctor, then there's a cash inducement to the provider. And we have had recent arrests. We've got good support from the police in terms of the kind of investigations that we're conducting and the evidence that we're accumulating, and so we're getting support from the police in acting in those cases, particularly where there's collusion. So very important to combat the fraud.
Then Bryan in Parkview says, why has there been a delay in allowing medical schemes to offer? Bryan, we've dealt with that, so we'll move on to the next email from Mark in Midrand. He says, if I join a medical aid, why do I pay the same as everyone else if I'm in good health? If you're over 35, you charge people penalties for late joining. If I'm very fit, shouldn't I get some benefit?
Yeah, such a good question, and that's the social solidarity, right? I mean, the social solidarity framework is this community rating where everyone pays the same contribution regardless of your state of health, and that's supposed to be around creating
not only state of health,
state
of income.
State of income. Well, no, we can differentiate. Some options differentiate contributions on the basis of income, but not on age, not on health status, or any of those factors. And so we look at other mechanisms to encourage people to look after their health. And we have been really amazed at the take-up of the personal health pathways in Discovery. How people have really embraced getting this information in terms of how to get healthier, and stay healthier, because that's our shared value model. You might not be able to get a discount on your medical scheme contribution, but the point is that if you are in better health, you obviously have higher earning potential, and you're living a better life, and it affects your family and your quality of life, and so those nudges which are helping people to maintain their health status. And Bryan, it's not just about these wellness actions, but some of the screenings have been really amazing in terms of picking up early. We've had cancer diagnoses being picked up early, doctors being reporting back to us cases where if this person hadn't been nudged through the personal health pathway to have that screening, that the opportunity to treat and manage that condition, if it had been picked up later, just wouldn't have been there. Yeah. So very valuable. We've got about 400,000 people now have taken up the personal health pathways and are getting those those nudges every week to help them to take good decisions.
Okay, I've got to sneak in one more email because this is quite important. He says, from Stan in Hout Bay, says, I'm currently with various specialists who are not network doctors and therefore charge substantially more than what the medical aids pay. In your opinion, are the medical aids trying hard enough to get more doctors to join their network system so that we can pay medical aid rates? And what do you suggest are our alternatives?
Yeah, so this is a very important question, and so important for member value, that you're not faced with having to pay out additional funds when you're getting treatment. So the first point to make is for prescribed minimum benefits. If you're using the designated service provider that the medical scheme has recommended, and you can find those, for example, on our Find a Provider on the app. You can find the providers that will charge at those rates. But for prescribed minimum benefits, you are covered in full. That's what the law says. You must be covered in full. So using the tools like the app, which indicates where the medical schemes have been able to negotiate full payment, we have an extensive list of doctors and specialists. It's over 90% of our services are actually covered in full by people when they're using those. Using the network providers. So the coverage is extensive, and it's a case of using the tools to make sure that the specialist that you're using is part of the network.
Yeah, there's so much more to talk about on that situation. Why aren't doctors joining the network system? What is it all about? But unfortunately, we've run out of time. I'm not even sure if I can do a closing because I think I've used up my time. All I would like to say is it's critical now. We're into November. Have a look at your scheme. Most schemes have pay brokers. If your broker's not doing the job, change your broker. You are paying for that, and get yourself a good healthcare broker who you can deal with. Roseanne, thank you for joining me this evening. It's important to note that our program tonight is to provide information and should not be construed as advice. Next week's program, we'll be dealing with, once more, I'm going to spring to that, we'll be dealing with short-term insurance, and if you'd like to get hold of me, you can deal with my details on the screen. Thank you for watching, and good night.